treatment with the weekly low-dose Taxol, you see that in the larynx cases, about 86% of them had at least 5 weekly doses of the Taxol. And in the oral pharynx, it was about 80%. When we looked at surgical interventions now, because this was for an organ preservation, non-surgical organ preservation trial, surprisingly, the outcome for larynx was not very good. 33% of patients required a laryngectomy. So that's no better than the radiation alone arm that I showed you with the R9111 study. And however, for oral pharynx, it was quite good. And here you see the overall survival, 80% at 2 years for oral pharynx cancer, quite surprisingly low, 58% for the larynx cancer group. So our conclusions, this data is also going to be presented at ASCO. Certainly the regimen was feasible. Surgical salvage rate of 33% for the larynx cancer suggests to us that our local regional control was poor, or in other words, the weekly Taxol regimen was inadequate. It was ineffective for local regional control. Induction chemotherapy didn't impact local regional control, or I think that we can say that if one's rationale is that if we give induction, then we can get away with a less intense concurrent, just radiosensitizing chemoradiation regimen. This study doesn't support that concept either. Disease-free survival and overall survivals are excellent for oral pharynx, probably because most of those patients are likely HPV associated, and we know the biology is different and that they have a better outcome. The other study I want to show you is the 9914 study, which has been published in the Journal of Clinical Oncology this past year. This was an RTOG study, 72 gray. You can see the radiation fractionation, accelerated fractionation scheme. Cisplatin, 100 milligrams per meter squared, day 1 and 22. Again, we have a predominance of oral pharynx cancer, 2/3 of the patients, and we also see that the median age of our patients, along with the oral pharynx, has dropped by about 10 years compared to past studies, which of course is going to impact our survival outcome. Here you see in this study that the survival at 2 years is about 72%. The study I just showed you in oral pharynx, it was 80%, with local regional failure and distant metastatic rates as shown here. The late toxicity, about 50% grade 3 through 5. The other study I want to mention briefly is the 9703 study, and this gets into the question of other cytotoxic regimens again. This study was a randomized phase 3 looking at 3 different combinations. One was limiting cisplatin and 5-FU in this low-dose regimen to the last 10 days of radiation when accelerated repopulation was expected to be problematic. The second was hydroxyurea and 5-FU, the University of Chicago FHX regimen, and the third was a regimen that we developed at Johns Hopkins and at the University of Pennsylvania, cisplatin and paclitaxel low-dose weekly. And again, 67% oral pharynx, 56 is the median age, and you can see it was a fairly advanced population. And here you see, interestingly, that the estimated two-year local regional failure rate is 41% for the hydroxyurea and the cisplatin 5-FU regimens, lower, so the trend for certainly a better outcome with the weekly taxane cisplatin regimen. And estimated 2-year survival, we see again that the cisplatin 5-FU given at the tail end of the radiation is poorer outcome than the other 2 regimens with more chemotherapy given throughout. and the same for pattern for overall survival. So I think this says that if one had to choose among these regimens, one could conclude that the limited low-dose cisplatin 5-FU to affect accelerated repopulation did not work. I think clearly we need randomized trials. We can't, with oropharynx, we can't use historical controls. These are two studies that the RTOG is doing, and they've been mentioned already, the accelerated fractionation concomitant boost with cisplatin versus standard fractionation with cisplatin. And then based on the outcome, there's in development a study of radiation with or without cetuximab. In the Eastern Cooperative Oncology Group, we're currently doing a study where we add cetuximab to an induction regimen and concurrent with radiation. And in the unresectable population, we're doing a study where we use, in the previous study and this one, standard fraction radiation with cetuximab added to standard cisplatin dosing and continuing for 6 months following treatment. So in conclusion, I think we can say that mixed site trials are useful for hypothesis generation and feasibility testing. Efficacy for local regional control may differ by primary site, mandating site-specific trials, such as what we've seen with this change in epidemiology for oropharynx cancer. And I think that we have to be very careful about alternative concurrent chemotherapy regimens to the standard cisplatin 100 milligrams per meter squared or cisplatin 5-FU. We should not assume that they are equivalent in efficacy. Thank you.